All right, welcome to part three of our concussion discussion. In this particular segment, we're going to outline more of the post-concussion syndrome clinical profiles. This is the meat and potatoes of things moving forward. I really encourage you to feel strong about these particular profiles. What examination measures might you implement for each one of these profiles? What are the common signs and symptoms that constitutes placement or categorization of someone into these profiles? Because then we're going to use these components to really dictate our intervention planning moving forward. So really important components in this particular segment. Take your time with this and feel really good with this information. Let's talk about each one of these particular clinical profiles. We're going to talk about each one of these individually, but I just want to throw a note out there that, as much as we'd like to be able to segment and say each one of these patients with post-concussion syndrome is going to kind of fall into one of these categories, it's more likely that they're going to fall into some form of combination of categories. So really what you're going to end up doing is a lot like we do with regards to setting up, primary and secondary impairment categories. You're probably going to have one that you're going to determine as kind of that primary or more dominant category at that time, and you're going to devote more of your time, effort, energy, resources to that primary category. But just keep in mind that there's these secondary things that we don't want to ignore, and we need to be able to track and develop important treatment plans for that. But that being said, we're going to talk about it more kind of in isolation, so that you can get a real good feel about what each one of these categories are. Okay, so the major categories are cognitive fatigue, a cervical category, vestibular subtype, post-traumatic migraine, ocular or visual category, and then mood anxiety. Let's start first with cognitive fatigue profile. This is the individual that typically feels really good in the morning, but they start to worsen as the day progresses. In fact, the more activity, the more effort, the more energy they do throughout the day, they'll typically report increasing symptoms. Usually it's headache. Again, number one most common symptom is headache. So headache's a great way to kind of gauge how well they're being able to tolerate the activities of the day. Okay. So track headache with any sort of activity, whether it's cognitive or physical, and you'll typically see those headache reports go way high by the end of the day. Patients in this category also typically have slowed cognitive impairment. It's typically global across multiple areas. This is the person that's scoring pretty low in most aspects of that impact test. Okay. They might be reporting that they have some attention deficits, or they're highly distractible. It's difficult for them to maintain focus. Their sleep may be deprived at this state. But one of the most significant symptoms they're probably going to be voicing to you is that they feel tired. They feel fatigued. They have reduced energy, and that continues to worsen as the day progresses. So hallmark of the cognitive fatigue profile, they feel better in the morning. They feel worse at the end of the day. Two most common symptoms are headache, that increasingly worsens with cognitive and physical activity, and fatigue. But in addition to that, don't forget about kind of some of those global, memory and attention issues that might be going with this particular person as well. The cervical profile, this is the individual that presents with neck pain. This is the person that you might state has cervicogenic headache. Right, so they might be reporting headache that's significantly tied to neck motions or sustained postures. You really understand that a lot of their symptoms are geared towards around the cervical spine region. Okay, again, we've talked about before the need to make sure you're clearing the cervical spine before you do any sort of higher level special tests. So make sure you rule out upper cervical instability or things along those lines, VBI, all that needs to be done. And then once you get into your further assessment and those are all fine, you'll typically see the person in this cervical profile actually have limitations in cervical spine range of motion, tension in the muscles, maybe trigger points. This is the person that you're probably going to incorporate some level of manual therapy intervention later on in conjunction with education, exercise, and posture training. Okay. Again, don't forget to rule out VBI or upper cervical spine instability. Those are things that I've been kind of harping throughout this. So this particular slide just trying to remind you of all the different things you probably already know about how to rule these things in and out. As I'm looking at the upper cervical spine instability, I'm seeing that I put on there the modified chart Purser, but there's also things like the alar ligament test you probably have learned as well. So make sure that you're doing your due diligence to screen and rule this out just to be safe for your patients. Let's move on to the next profile. It's the vestibular profile. These are the individuals with their primary complaint is typically dizziness. That's not to say that they won't have a headache, but more times than not, you tend to see someone in this vestibular profile probably with dizziness as their primary symptom and headache a little bit more secondary. If they have dizziness, you really need to start to differential diagnosis the root cause of it. It could be benign positional paroxysmal vertigo or BPPV. It could be motion sickness. It could be hypofunction of the ear. There are a lot of different things that could be creating dizziness. So part of this role is to be able to really identify the root cause of it so you can treat it appropriately. We're not going to talk too much more through the rest of these segments on interventions for the vestibular profile, but you are going to get that heavily in the next segment of the course on vestibular examination and treatment. So just, again, appreciate that just because you're learning something later on in the semester doesn't mean you don't need to pull that information back into this concussion patient population, because vestibular profile is really common post-concussion. And as we said before, it's one of the most common profiles where that person is going to have more likely going to have a prolonged recovery from concussion. Post-traumatic migraine profile. This is the type of headache where it's typically unilateral. They'll often wake up with a headache, not to be confused with the cognitive profile where they typically have a headache develop more towards the end of the day, but they feel really good in the morning. This is a person that feels bad from the very beginning. All right, and that typically that headache may be associated with nausea. They may be sensitive to light, maybe sensitive to sound, and that might actually aggravate their symptoms even more. This is not typically the person where you'll see them do neck range of motion and say, oh my gosh, my headache is so much worse. It's typically a type of headache that's separate from those provocative testing that you would do for the C-spine. Okay. It is variable in nature. It's intermittent. It's hard to gauge when it's going to happen. Some patients will report auras or things like that happening beforehand that help predict that this migraine is coming on. As much as I would love to say there's a lot that we can do in physical therapy for somebody that fits this profile, the most common intervention pathway for this person is actually referral back to their medical provider, probably for pharmacologic intervention. They're probably going to be better off with pharmacological intervention than anything we can really do in physical therapy. Okay. A couple of the factors associated with post-traumatic migraine are who's most likely to fall into this category. It's typically the younger population. For some reason, it's typically those involved in a motor vehicle accident, and it's typically female. I cannot really explain to you why. These are just correlative things that we've seen throughout the research, but I can't really explain to you why those individuals are more likely to fall into the post-traumatic migraine category than any others. And as I was saying before, referral for somebody in the post-traumatic migraine is probably indicated. But don't forget that big picture thing of just because their primary category might be post-traumatic migraine, that's not to say that they don't have other categories of issues that you could address. Like maybe they do still have some vestibular issues with it that we could treat. It's just for the post-traumatic migraine component of things, you're probably best off with referral. Ocular or visual profile, these are the individuals that will commonly report headache associated with visual tasks, right? Like computer work, anytime they have to scan things in their environment, move their eyes back and forth. That headache's usually associated somewhere in the frontal bone region between their eyes or their sinus area. But they're typically ones kind of telling you my eyes hurt, my forehead hurts, I hate working on the computer, I can't read, the print is too small. Maybe they report their vision is a little blurry, or they may even have double vision. These are the individuals that would kind of fall into this ocular visual profile. This is another one of those biggie categories where they are just more likely to have a worse recovery process than some of the other profiles. Okay, so if they fall into this category, there's definitely things that we can do to help improve their overall condition. It just may take a little bit longer to get them where we want to be than maybe somebody that falls into that cervical category. The mood anxiety profile is our last one. This is usually the one that's telling you about their feelings of being overwhelmed, person that has a lot of stress, they're reporting anxiety. They're usually the ones that are kind of withdrawn into their room or kind of pulling away from social activities. They may be reporting intrusive thoughts. They're very emotional, and those emotions happen fast, and they happen suddenly, and they can have dramatic bursts and changes of their emotions. These are individuals where you can really help with things like exercise as improving mood and improving their independence and their function. But that being said, those are usually secondary mechanisms to help treat somebody in this profile. Similarly to what we talked about with a patient that is primarily in the post-traumatic migraine category, the person in the mood anxiety profile is definitely somebody you want to refer. We really need to pull in an additional practitioner to help us manage this patient, perhaps psychology, counseling, psychiatric help. Those are things that you're going to want to encourage this person to engage in. And then your role becomes secondary in helping to reinforce how to manage the situation to reduce their feelings of being overwhelmed, distract them from the focus on how they're feeling to how they're functioning. Much like you might do with somebody that has chronic pain or something along those lines. So the mood anxiety profile, if somebody has that as their primary category, again, you're probably thinking referral, but just don't forget about all the benefits of exercise and what that can do to somebody's mood, anxiety, stress, and focus on function and how that change in function can improve the outlook of the quality of their life. Those are all things that secondarily you can do to help somebody in this profile. It's just not probably the primary treatment method. Right? And those are the major clinical profiles. So again, go back, look through this, listen to this lecture a few times, make sure you feel really confident with this particular presentation of individuals, because this serves as the very basis of everything that we're going to do next week when we're talking about PCS interventions. Okay, so part 4 we'll actually get next week. You'll have an RA for that specific to interventions. Make sure that you read through the MTBI clinical practice guidelines. That's going to be really important for how to approach interventions for some of these major clinical profiles that we can really feel like we can make a major difference with. There's not a great clinical profile intervention guideline for post-traumatic migraine, but you better believe there's a good approach for cervical, right? And there's a good approach for somebody that has that ocular, visual, or vestibular. So we're going to get more into the meat and potatoes of interventions next week. But in order for you to feel really good about how to implement that treatment plan, you really need to have a strong understanding of these clinical profiles to the level of what are they going to look like, how are they going to fall in it, and I would encourage you to think that next level of how would I have found out this person belongs in this category? What's some of the subjective questions I would ask that would have led me towards this particular profile? What types of examination findings that we talked about in the first two lectures would I probably see positive for the cervical profile, but not for the vestibular profile? Get into some of that thought process about differential diagnosis of the exam so that you can appropriately classify each one of these patients into their primary clinical profiles. All right, we'll see you all in class. If you have questions, feel free to email me or, ask, while we're in class or after class. I'm happy to help as much as I can. Otherwise, thanks everyone. Have a great week.